Hello everyone, my name is Jaehyun Kim. Today I will present our study titled Comparative Outcomes of No-Touch Radiofrequency Ablation versus Tumor-Puncture Microwave Ablation for Small HCC. Hepatocellular carcinoma is one of the most common primary liver cancers. Percutaneous ablation along with surgery and transplantation is a main curative treatment. Among ablation methods, radiofrequency ablation and microwave ablation are widely used. A critical factor is achieving a safety margin over 5 mm to reduce local tumor progression. However, conventional tumor puncture carries a risk of tumor spread. The no-touch technique avoids puncture the tumor directly, which may improve local control. No-touch RFA has some advantages in making large ablation zone and reducing local tumor progression rate. Microwave ablation is less affected by the heat sink effect, allowing it to create a larger ablation zone while also requiring less time. Our goal was to compare outcomes between no-touch RFA and tumor puncture microwave ablation in patients with a single HCC of 3 cm or less. This was a retrospective multicenter study at 5 hospitals from 2016 to 2020. We included 304 patients. After propensity score matching, 81 patients in each group were compared. To minimize potential biases from baseline differences between the two groups, we performed propensity score matching. Variables such as tumor size, tumor location, liver function parameters, and whether the tumor was recurrent or treatment-naive were included in the model. This is the flow diagram of our study population. After propensity score matching, 81 patients in each group were analyzed for outcome comparisons. We evaluated both procedural outcomes and oncologic outcomes. First, technical success was assessed based on complete tumor coverage on immediate post-ablation CT. Second, post-ablation complications were analyzed, with major complications defined as grade 3 or higher according to the SIRS classification. Finally, oncologic outcomes included local tumor progression, intrahepatic remote recurrence, and recurrence-free survival, which were analyzed using the Kaplan-Meier method. Let's move on to the result. After propensity score matching, there were no significant differences in baseline characteristics between the two groups. In the overall cohort, the no-touch RFA group achieved significantly larger ablation zones and greater minimum ablative margins compared with the microwave ablation group. In addition, no-touch RFA had a higher rate of achieving a margin of at least 5 mm. However, this came at the cost of longer ablation times. These differences remained significant even after propensity score matching. In the overall cohort of 304 patients, initial CT scans showed complete tumor coverage in 98.6% of no-touch RFA patients and 100% of microwave ablation patients. This difference was not statistically significant. After PSM, the technical success rate was 98.8% for no-touch RFA and 100% for microwave ablation. Again, no significant difference was observed. There were no major complications in either group, confirming that both methods are technically feasible and safe. Regarding local tumor progression, the no-touch RFA group demonstrated superior local tumor control compared to the microwave ablation group before and after propensity score matching. This suggests that avoiding direct tumor puncture may reduce the risk of local recurrence at the ablation margin. This is the Kaplan-Meier curves of local tumor progression. Regarding intrahepatic remote recurrence and recurrence-free survival, there were no significant differences between the two groups. This indicates that while no-touch RFA provides better local control, the overall risk of tumor recurrence elsewhere in the liver is similar. Here, I would like to show you a representative case of no-touch RFA. On the coronal hepatobiliary phase image, you can see a 2 cm hypointense lesion located in segment 8 of the liver, very close to both the portal vein and middle hepatic vein. In this case, 3 electrodes were inserted outside the tumor boundary. The immediate post-ablation CT images, both axial and coronal, show that the ablation zone completely covered the target tumor with a minimum ablative margin greater than 5 mm. Importantly, the follow-up CT performed 40 months later shows no evidence of local tumor progression. This demonstrates the effectiveness and durability of the no-touch technique even in challenging tumor locations. Now, let me show you a representative case of tumor-puncture microwave ablation. On the arterial phase CT scan, we can see a hypervascular lesion consistent with HCC. For ablation, the antenna was directly inserted into the center of the tumor. The immediate post-ablation CT demonstrates that the ablation zone fully encompassed the tumor with a minimum ablative margin greater than 5 mm. On follow-up CT performed 40 months later, there was no evidence of local tumor progression. This case illustrates the effectiveness of conventional tumor puncture microwave ablation in a favorable location. In summary, no-touch RFA achieved better local control than tumor puncture microwave ablation, although the procedure was more complex and time-consuming. I would like to thank all my colleagues from the 5 participating hospitals who contributed to this study. Thank you very much for your attention.